We're going to cover labs, IV fluids, other fluids, blood orders, shock, sepsis, and we're going to enter sepsis today, and sepsis protocol and SOFA score. And we'll cover that. This PowerPoint is on Mesa, and also the study sheets are there as well. And on Nursing Camp, all the study sheets. All right, so let's get into it. So, IV fluids. All right, so we said that IV fluids are important because they're all based, if you have IV fluids in the question, it's about the IV fluid. And we said that, you know, there are some certain things we need to know about IV fluids when we start to think about them, whether they are crystalloids or colloids. And we said that crystalloids is then broken down into hypertonic, hypotonic, and then isotonic. And colloids are everything else, right? So colloids are generally like albumin, heterostarch, and colloids are like collect in the vasculature, right? Where we don't want to really have fluid shifts and different things like that. But we'll talk about that, like I said before, with albumin. We do use it in sepsis. However, our mainstay is generally these three, these crystalloids, and that tends to be the priority because peeing, puking, or pooping are going to affect this area over here. But we also monitor the hematocrit because that makes the patient dry. We talked about electrolytes when we talked about blood yesterday, calcium and mag, and we talked about citrate toxicity. And we drew this upside down because of calcium and mag go down with multiple transfusions, so you look for hypocalcemia. Sepsis is definitely there, PT, PTT, fluid status, and so on. All right, so crystalloid fluids. And why do we know? Why do we need to have fluids? Is because of mean arterial pressure. Mean arterial pressure, but we said that, you know, brain is 70-75, and then you have, you know, kidneys, right? Kidneys are 60-65. And kidneys, you know, are BUN and creatinine. And we talked about that with sepsis, and sepsis is important because of, we're always looking for this. We're worried that the patient is going to become intrarenal, moving from pre-renal to intrarenal. And pre-renal is elevated BUN, normal creatinine. But if I start to see this patient who's septic, who vasodilates, I'm giving them all these fluids, I'm trying to maintain their kidneys. I need their kidneys to be okay. And the reason that's important is because I can put a Foley in them, and if I start giving them all this fluid, they're going to start this third space if they're in renal failure. And then that becomes a bigger problem. Then it becomes Stay Puft Marshmallow, and they blow up, and they start to weep with edema, and they have +4 edema. We need to know the kinds, 3 different types, but we said that assessment is more important out of all of it. That's the A-core assessment, where I talked about how it's generally how I look at any kind of IV fluid that's on board, you know, because it's important to know, because you just don't walk into the room and normally see IV fluids, right? Well, in the hospital you might, certain floors, but generally most patients don't have it. So if they do have it, how's it affecting the patient assessment? So what we said that first thing is assessment, and then that's lungs. And lungs is generally priority. So lungs are always priority because we're always going to assess before we implement. So we usually assess the lungs way before we ever give any IV fluid. And that's important to know. And that's also with blood, right? So we learned that we were talking about blood and patients with CHF, you know, you assess lungs before that. Because if they suddenly start to have shortness of breath or crackles and they're CHF patient, you're giving them blood, you know, what was it before? Right? So that's important to check. So we're going to go back and check. So we're going to do it first. So we always assess lung cells before, prior to it. So that's a good practice. You might assess labs too, right? So labs and breathing. How well is the patient breathing? Is it compatible with other IVs? And we talked about that with lactated ringers, right? So we said lactated ringers, patients with liver problems or renal problems. We generally tread lightly with that. But we said it's a bigger deal because of CLAPS. And CLAPS is all the things that are in lactated ringers. And that's what makes it incompatible with things. But we learned that IV fluids, normal saline isotonic is good for normal blood transfusions, and that's why we use it. So you don't use anything else other than normal saline for blood transfusions, even though it's isotonic. And so isotonic, there are three different types, right? So we have the land, high five, high is dry. So patients with LR is isotonic. This is for any normal patients, right? So, I mean, they generally will get that, normal saline, and then D5. And we said that D5, you know, is hypotonic but isotonic in the body, right? So it's got a lot of fluid in it, but it's generally hypotonic. But when it goes into the osmolarity of the body, generally it's very similar. And you can see this osmolarities over here. They're all kind of similar, about the same osmolarity rate. All right, what else? We said that compatibility is important because when we're looking at these types of things, why is it ordered? You know, why does a patient get lactated ringas? And we said that that's the bump and, you know, burns, you know, maternity, post-op, and urgent trauma patients. Sepsis is also another thing too, because a patient who's septic, sometimes it's not normal saline. You don't want to give them all the saline, but you want to give them a little bit of these electrolytes because they have mass inflammation and mass damage, and so we want to support. It's got a buffer in it, it's got lactate in it, and that keeps them a little bit less acidotic, so it's a good thing for that. However, a patient who's on lactated ringas for a longer period of time becomes more complex because they can't keep on getting all these claps, right? So you never leave running lactated ringas, right? What else we got? So then we have why. Why is it running if it doesn't need to be? You know, if the person's having a hamburger or something like that, doesn't need to be. Then we moved into hypotonic. So hippos, right? So, you know, makes the cells swell, right? So all this fluid that's out here in the ECF suddenly goes into the cells, and the cells start to swell up. And that becomes, you know, that's problematic, right? So, I mean, it's going to lose. So if somebody is euvolemic and this really filled, they actually become hypovolemic, and that's acute, right? So, I mean, so blood pressure starts to drop, and so it's blood pressure, right? I mean, it's one of those things. So, risk is also some fluid overload because of think of crackles and different things like that. Next is hypertonic. So, hypertonic is where you have your cells, right, and then hyper, right? So they lose weight, they start to get skinny, right? So so all the water will basically go outside the cells, right? So they go outside the cells. Where do they go? Well, so if you had somebody who is normal volemic, and suddenly they're pushed into these cells, right? I mean, into this vasculature, right? They become fluid overload. But we said that this is good for like patients with brain injury, because brain injury is important because osmolarity. And we look at this osmolarity of these, right? And sugar, water. And we said that mannitol is generally the treatment for brain injury. So therefore, this is usually the closest to it. You know, so it doesn't mean it's the number one priority, but I mean, generally mannitol is and other medications, but not generally these. But I mean, it's just splitting hairs about the questions and different things like that. When you're tested on that, and the NCLEX is generally based on fluid status, blood pressure, lung sounds, and assessment of it. All right. Let's see what we got here. Is tennis need to know, good to know? No. NCLEX will never test you on the osmolarity of IV fluids. It's mainly about fluid shifts, understanding the concept of hypertonic, hypotonic, isotonic, and, basically everything I'm talking about. So, there's nuts to know with this stuff. So, I mean, like all that stuff of, what's in lactated ringers, that's nuts to know. I mean, you don't need to know all that. You already do know it, but it's not need to know, right? Because the concept, what's the concept? You never leave it running. Concept is it's not really compatible with most things. And you don't give it with blood, even though it's isotonic. You don't give dextrose and water with isotonic. So this is kind of generally things that you're tested on, especially NCLEX. It's always lung sounds. I just see serum osmolarity. Yeah, osmolarity, serum osmolarity, and urine osmolarity is always about concentration, urine concentration, and dehydration, not on IV fluids, right? So IV fluids would be nuts to know. Like, I don't even know. I don't memorize all this stuff. Like, I don't need to know it, I mean, I just need to know it's isotonic. I didn't know it's hypertonic and hypotonic. That's the most likely as far as being tested on. Because what's the risk? What's the safest action? The safest action is that you don't give D5 to patients with a head injury, right? And even though it's dextrose, right? And the thought process is, well, put dextrose with water, we don't do it. Dextrose with normal saline is okay. Okay. More important is knowing that, right? It's the same thing with normal saline versus lactated ringers. As far as like post-op burns patients, those type of things. And also knowing that, I mean, that's, I think even nuts to know is the LR, liver, and renal patients. I mean, it's very easy to remember. I mean, so you can get to that answer. But I think that if I was to pool everybody in the class prior to this, I mean, nobody would know of this, right? I mean, either you picked it up somewhere or but prior to this class, you probably would never even thought of that stuff. It's just what it is, right? So that makes it nuts to know, right? So, which makes me a different teacher than a teacher that's teaching wherever, right? I mean, are they going to talk about it? They're like, oh, lactated ring is the same as, whatever, or they go nuts to know. I mean, that's why those videos online and different things like that are sometimes just so much information. You don't need to know. I watch them, because I'm doing research, and sometimes I'm looking at it, I'm like, this is too much information. Like, why do you really know all this stuff? Like, you're not gonna, it's not applicable, The biggest key is dissecting that information and saying, if I had this information, this is how it's presented, this is what I'm most likely to be tested on. But it's not teaching to the test. I'm teaching you practical knowledge about, this is what I would do in practice if I saw lactated ringers. I would still look at the BMP, and I would know about potassium, I know about liver, I know about renal, which is very valuable information, and it's more than most graduates would know. So, but you're not tested on it, get it? But it's very practical because you can remember it. Unless you're like, I don't remember any of it. That's just what it is. All right. So let's get into that. So we get out of that. Then we talked about this. I mean, this is just familiarity. Right? HESPAN, those type of things. FFP, these kind of show up in questions, but it's always generally around lungs and fluid and all that stuff. If you're doing Saunders questions, different things like that. I always say Saunders just because Saunders is heavily comprehension. That's the only reason. When they're even on IGI and your book and stuff like that, or ATI, I mean, they're testing whether you read the book or not. You know what I mean? They're testing at a comprehension level. All right, so platelets, mannitol we talked about, and then we got into blood. All right, so now we're into blood, and some basic things with blood was that time, always time. Because we have to look at it in the approach of a question, because you're going to be administering it, and so it's going to be giving you the scenario. Right? So it's the same thing as, maternity nurse comes down to the cardiac floor. They're giving you a scenario. So they're saying, okay, well, same thing as a chest tube, right? You're getting a chest tube, you're monitoring a chest tube. Your question is, when am I monitoring this? Right? That's important. And if it's unquantifiable, it's a general question. Right? So same thing is with blood. When is this happening? Where am I? Am I just starting? Am I not? Because time is everything. In the first 15 minutes is acute. But that is actually pushed up to 30 minutes because we saw that after that, 30 minutes is this is generally bacterial. Now, bacterial is acute because it could lead towards sepsis. But it's not like, holy crap, call the doctor, it's got bacterial. No, do blood cultures, do urine cultures, send the blood to the lab, do what you're supposed to do. You probably anticipate antibiotics, Tylenol, those type of things. But it's not going to kill the patient today. It'll kill the patient tomorrow, day after tomorrow, right? If they become septic. But it's not going to kill them now. That's different with time. All right, so with blood, we talked about H&H. We talked about how that's important, hemoglobin and hematocrit. And we talked about how hemoglobin, we said 1, 2, 3, 4 spaces. WBC is 4. This looks like a 10, so that's 4 to 10. 10 plus 4 is 14. That's 14 to 18 is a male. And then we said 12 to 16 is a female. And then we talked a little bit about that. And so generally, if you have hemoglobin in a question with no sex in the question, right, generic question, that's it. But they're not going to have you memorize, 10, 9, 8, they'll give you 6 or something like that. You just need to know that's low, right? Just that the lab value, right? Not the splitting of the years. So then the second concept is the hematocrit, right, which is triple. So whatever this is triple. So if I had a hemoglobin that was 10, well, that's low, no matter which one. I would expect that hematocrit to be 30. Okay. So if it is 30, okay, even though it's low, they're okay as far as hemodynamics concerned. However, if I looked at the hemoglobin, it was 10, and then the hematocrit was 45, this patient's dry. So I'm going to look at the BUN, right? I might look at sodium. I might look at diuretics. I'd expect this to be abnormal, and so on, okay? Because these are all factors that says the patient is dry, right? Peeing, puking, pooping, diuretics, drains, and so on. All right, so triple hematocrit. So what about the reverse, right? Well, that's not most likely, okay? Most likely is you're tested on this. There is a principle behind this. It's just the opposite. So hemodiluted patients would be lower than that. So they're fluid overload, okay? So why is that important? That's nuts to know, not need to know. Okay, what needs to know is this. Nuts to know is hemodilution. Well, hemodilution is important because of hyponatremia. Because we said the hyponatremic patients, we didn't know what kind they were. Right? Are they dry? Are they euvovolemic, or are they hypervolemic? For the NCLEX, all you care about is hyponatremia is fluid overload, period. Okay? It's just what you care about. That's what you're tested on. They will not make you split hairs. But the risk is seizures, coma, fast-like symptoms. All right, so that's blood, and then we talked about, of course, we're going to monitor coags, all that stuff, and then we're going to talk about the orders of process, right? So benefit versus risk. Never treat the monitor or the labs. Always look at the patient, what the patient has, right? Where am I in giving this blood? Am I in the emergency room or am I on the floor? Okay, that's two different areas because the emergency room is a different treatment than the floor, right? Because now we have trauma, okay? So now we have trauma questions, right? So we talked about blood types. And then we said that, we're looking at blood types. We talked about this right here, typing crossing. Right? So, well, if you're in the ER and the person's bleeding out, they're in a multi-car accident. Well, how many cars are there? I don't know, 300. Could it be? Oh, of course it could be. Right? Could it be a meteor shower? I don't know. Right? The fact is, do I have my trauma hat on and think the worst case scenario? Okay. So do I have time to type across? No. So I have to know some concepts, right? So we need the universal donor. Oh no, oh yes, O negative, right? So O negative is the universal donor, right? And any blood is positively the universal recipient, okay? Which means they can receive any blood. All right, so that's important to know, but that only shows up in trauma. Okay, it's not going to be on the floor. You're not going to be like, oh, I need to, the type of thing, because patients on the floor are not going to be. You're not going to be presented in that situation. This patient bleeding out in front of you, and you need to, you'll type and cross, and so on and so forth. All right, so then we talked about this, and we talked about how we do this, right? So we do OA, B, AB, and compatibility OA, B, AB, and this goes like this, right? And that's compatibility. And, this is just being fancy about it, all right? So, looks cool. All right, so O negative, AB positive, packed PRBCs. You don't care too much about this stuff, platelets and pools and stuff like that. That's nuts to know, right? So, like I said, this is from my advanced med search, more of an ICU intro book. Okay. Albumin we're going to talk about today with sepsis, and then so let's talk about the process. So never treat the labs. But a lot of it's based on current policy, so there's a lot of that issue there. So like when you call the doctor, when you don't call the doctor, those type of things. I mean, standing orders. So it's going to be very complicated because as you're doing questions in ATI, Saunders, different things, it goes back to that nitro question. Remember that nitro question was sublingual when you call 911, right? They're all over the place with that, right? Some are like, oh, well, if it happens now, you need to call it. But then the book says, no, you should take 1, 2, and then the third one. A gray area, okay? So there's a lot of policies about when you call the doctor, when you don't call the doctor. More important is you stop the transfusion in 15 minutes. So you always say to yourself, in blood, is what I'm seeing safe or unsafe? And once you have that, make your actions. And then you anticipate your other actions based on that. Okay, so as we move into it, we have, we don't care about anemia, right? Because anemia is generic and it is chronic, right? So our patient's anemic, you're going to give them blood. No. Okay, so we treat the underlying cause for anemia. That's nursing too. That's where you learn about microcytic, macrocytic, pernicious anemia, and all those things or not. What are you responsible to know? You're responsible to know for NCLEX, pernicious anemia, and that's the main one they usually test on. Sickle cell, those type of things. Well, that's covered in generally Brenda's class. And, sickle cell in a nutshell is pain, number 1. Mass inflammation, number 2. Hemolysis, right? And hydration. Keep fluids, and pain. That's sickle cell in a nutshell, right? Sickle cell also is exacerbated by cold. So therefore, think about it. It comes from Africa, right? So, I mean, it's protection against malaria, right? So hot, warm. So it's very fascinating when you see somebody who's living in upstate New York with sickle cell, because why would you be in an environment that's going to have a higher risk of continuous exacerbations of sickle cell? You know, these patients tend to be more in the southern states because it's warmer and it's less likely to have an exacerbations. Yeah, but I mean, you're geographically caught where you are, but I get that. But generally, a lot of times when you see people who have sickle cell crisis and they come in, pain, and it's what it is. You can't say they don't have pain, right? So the sense to be a psychosocial aspect to it as well, you know. So it's a fascinating type of thing. Jehovah's Witnesses are important. Autologous, we talked about badges, bans, and policies. 15 minutes, 4 hours for the blood. So we said timing is important. When blood comes up, you got 4 hours to deliver it. Okay, so that's drip rates, all those type of things. 15 minutes is when something bad's going to happen. So in that 15 minutes, that's about 50 cc's, and that makes it acute, right? So always look at the timings. That'll get you closer to where you need to know about what you need to be familiar with. All right, so the next thing is this right here. So we said citrate toxicity is mainly because of, this is basically our calcium mag, and we say that that is low, right? So calcium and mag are low, and this patient will get calcium gluconate, calcium go, right? Good to go with calcium gluconate for hypocalcemia. We don't worry too much about magnesium, you know, because calcium is a stronger ion mineral than magnesium is. So it's just a mechanism of action. There's more of an abundance of calcium than there is magnesium. Magnesium is more for muscle, and that's why we see it as a tocolytic. And you learned in Brenda's class or not, you know, about tocolytics. And so you're tested with magnesium with hypermagnesemia, magnesiemia, right? Yeah, you know what I mean. And that is slow-like symptoms, right? Except for blood pressure. All right, so next is timing. So then we looked at this schedule right here, and we said that it can get very confusing. So you have to start to do questions, right? So to say, okay, well, what's the time in this question? Okay? So if you can't quantify the time, it's a generic question about blood. Okay? Then your second thing is it safe or is it not? And once you know that, make your decision based on what you're seeing. Okay? So generally, rule of thumb is less than 15 minutes, you generally stop. But if it's an hour into it and you're like, this is bad, I'm going to stop it. Because you're going to be like, no, hold on, I'm going to go call the doctor about this. Meanwhile, that blood is still running. So don't do that. So you have to say, okay, well, you know, hey, you know, what's going on? So that's what we want to do. All right, so let's talk about what we see. Now, what we see is vagueness. Okay, so this is nuts to way up here. This is kind of why it happens. But more important is you see this kind of, now getting this right here and doing the research on this, talk about gray. Talk about all over the place. Those symptomologies are all over the place when you're doing questions. Okay, remember, when you're doing questions in books, they're not written correctly. They're all over the place. So most important, it always goes back to safety. And when you're looking at NCLEX and NCLEX questions, safety, right? And that's the priority action. When you're looking at Saunders or Davis or Kaplan or UWorld or Lippincott or whatever, you're looking at all these things. You got some yokel who's writing a question. You know, like I learned it this way. This is what it's going to be, right? And they write the rationale, and then it makes sense to them. And then you have a student that's looking at it like, well, wait a second here. You know, here you do this, and over here it's over here. What the hell? You know, that's wrong. You know, and then but you can't talk to anybody, right? So you're kind of like, this is BS. And so then you text them, hey, did you see this question? Gavin said this, blah blah blah, and I see this, da da da. You know, well, that's, take it with a grain of salt. All right, so your assignment is to practice that, is to look at these questions, to look for that stuff and see that this part. But what I've tried to do is that I pull this kind of what I've seen as the most important things here. And what I see is, and if you think about this first one, a hemolytic is breaking up, gets stuck in the kidneys, hence flank pain. I've seen flank pain, lower back pain, very specific. That is different, you know, I mean, because sometimes, think about what's going on. These lysis is happening all throughout the bodies within the first 15 minutes, so therefore pain is coming in. You have an occlusions, right? Well, that's different than when you have itchiness. Right? So itchiness with a mild allergic. Well, first of all, we have anywhere within 24 hours this patient's going to be having this. Right? So if they start to get itchy, you know, fever, you have an inflammation response, right? So think Benadryl, corticosteroids, and different things like that. Non-hemolytic, headache, muscle aches, respiratory arrest, most likely. 15 minutes, then we go into timing. So you want to do this 15, 30, and then and just say, okay, where am I in this question? Okay, and then based on that, then you can kind of get to where you want to go. But it's a good research right now as you start to do questions to kind of say, okay, well, this one's saying this. This is how they're trying to do this, and that's what you want to try to figure out. NCLEX will focus on safety. Is it safe? Is it not? Would you normally keep something running or not? You know, generally, or you're just going to medicate it. Right, and that type of things. If they have medications on board, it's usually anticipated orders. Okay, patients presenting with, you know, 2 hours into the transfusion, after the transfusion was stopped, you know, what was an anticipated order, right? And the order might be Tylenol, Benadryl, you know, and you have to say, okay, well, that's a mild allergic. Okay, that's Benadryl. All right, or you know, the patient is 2 hours post-transfusion, you know, is having vomiting, diarrhea, and fever, you know. What's a nursing priority action? Blood cultures, okay? And that's kind of where it comes in. So, I mean, it's just recipe, but when you're doing questions, you get grayed out. You go all over the place. It's like that chest tube question, popping out, going back in, all those type of things. The trade question coming out. You see it just over and over again, then it becomes very complicated. I say, what is it talking about now? You know, 1 minute's over here to there. So that's what you try to want to figure out. And then we have the CHF question you hope for, because out of all of them, that's the easiest one. I mean, that's all the other ones you kind of generally stop. But CHF, you tend to just slow it down. You know, assess the patient, goes. You know what I mean? If the patient is complaining of shortness of breath and they have the blood running, you have to say, is this safe or is this unsafe? Is there any data in the question? You know? And you can assume the person has CHF, get it? So if the patient says they're short of breath and the blood is running, you know, you can assess lung sounds, right? I mean, because are they CHF or not? Because if I assess lung sound, then it crackles. So think about this: patient is receiving blood and is short of breath. Do I stop the transfusion? There's not enough data in the question. It requires more data. You assess just because they said they were short of breath, and that goes back to subjective, based on what they're just saying to me. Okay, and so therefore it needs assessment, objective. Okay, so it needs assessment of that patient. What else we got? So steps of it, you know, I mean, we talked about UAPs can do it. No LPNs do blood. 2 RNs do it. And doing, what else is there? 2 RNs, so then process, right? So vital signs are in, you're late, and then no LPNs. Yeah. What else is it? So vital signs, UAP, 15 minutes before, 15 minutes after. RN stays in the room for 15 minutes. So you do set of vital signs, then you go 15 minutes. Does that nurse do that first set? Well, if the transfusion hasn't started, the UAP can do that first set 15 minutes before, right? So that's the baseline, right? So I think it's a little bit gray out there as far as, just immediately starting who's going to do that first set. If the RN's in the room, the RN would do it. Makes sense, right? Because if you're going to be in the room administering the blood, then you're going to do the first set. Now, I've also seen policies where I've seen 5 minutes and 5 minutes. Well, I mean, that's where it starts to get confusing. So less than 15 minutes is priority. All right, and then we go on these bases at least times. All right, any other questions? Sepsis can be the same as anaphylaxis. I saw questions that had the same signs and symptoms as anaphylaxis. They're both acute. Stop it. Stop the transfusion. Anaphylaxis, you wouldn't do blood cultures on, right? I mean, why would you do it? It's not a septicemia. Yeah, and questions will be, yeah, I mean, they are kind of very similar. And the symptomology is very difficult to say. Everybody's agreeing that these are the symptoms. I mean, you only see this, vomiting, diarrhea with specific bacterial febrile. And you only see this, urticaria, itching. Right? So if you think about this is more chronic, itching. You don't go to the doctor, holy crap, I'm itching. You're not going to go to the doctor, right? So, I mean, that's a mild symptom. However, wheezes, you would go to the doctor for wheezes. Okay? And that's kind of where that works. Yeah, the questions will be all over the place, which means that I don't split hairs on that stuff. And also NCLEX will not split hairs on it because it's just nobody in the room can all agree that this is what we're going to say it's going to be. However, hemolytic flank pain tends to be what it is, right? I mean, that's flank pain, right? So that means side pain. That's everybody's fine with that. It's the other stuff. Also, urticaria. People are fine with that being the mild allergic and stuff like that. Wheezes, people are fine with that being anaphylaxis. So there's some specific things. The hypotension kind of goes all over the place. The chest pain kind of goes all over the place, sometimes with anaphylaxis and sometimes with non-hemolytic, which means it's kind of gray. So, I mean, you get your work cut out for it. All right, so the time, yeah, so the time is everything. Yeah, so always, I would just put down that 15, 30, 6, 24 hours and say, where am I in this? Okay, because if you can't quantify it, then is it less than 15 minutes, right? So if it's less than 15 minutes, you hold it. If you don't like what you're seeing, you don't know what it is, and you don't know what the time is, you hold it. You pull the blood down, right? So you recognize it as a problem. So, yeah, the only problem you're going to have is when you're looking at questions, and you see a lot of questions that are contradicting each other. And that's the frustration of it, which means that's a school issue, right? That's a school testing issue, not an NCLEX issue, because NCLEX is going to be safety and compatibility and whether there's an acute problem, okay? And that's the thing. And that the basic rules of types and crosses as far as 2 RNs, consents, all those type of things, right? And that LPN or UAP doesn't take vital signs while they're doing it. They can do that 1 hour later, right? Because 1 hour later and stuff like that, you're only in there for the first 15 minutes. But after that, it doesn't really matter. Well, it does matter, but you know what I mean. All right. All right, let's move on. Any other questions? So what is a delayed transfusion reaction? A mild allergic, right? So that's delayed, right? So I mean, it's a still reaction. A bacterial is a delayed transfusion reaction, right? So I mean, it's not going to kill the patient, but they're still having a reaction. So all these things are reactions. However, less than 15 minutes is an acute reaction. All right, so septicemia and sepsis are kind of the same thing, or is that totally wrong? No, it's not. The septicemia, bacterial leads to septicemia, right? So, I mean, we catch it because that's why we're doing vital signs, right? So we catch it, we do blood cultures, we prevent septicemia. All right, so ensure blood products obtained. Okay, so time is a factor. Vital signs, baseline, CBC we talked about. You see why there's calcium, magnesium, those multiple transfusions. So now, like, that's one of those things that's important to talk about because we might not have talked about that, right? You might be, now that's nuts to know, right? However, you know, I mean, it depends on the teacher. It depends on the teacher that they are focusing on something like that or they talk about it. And then you can see, because if you never were in this class, you know, you might be like, why the hell are they checking calcium and mag, right? And why is it calcium gluconate? All those type of things. It doesn't make any sense because you might be in that class where they just do a blood lab. And it's all about the task of doing it, not the aspect of doing it. All right, so this is kind of universal, right? PRN, that's pre-medicating. They would give you that pre-medication only if they're going to give you the answer, right? They're going to say the patient has a history of XYZ, you know, mild allergic reactions. You know, what is a nursing priority action, you know? And if it gave you the opportunity to pre-medicate with Benadryl, then you do it. Right? Because you know, okay, well, that means that. It's not acute, it means it's a mild reaction. But it wouldn't be like, oh, I need to notify the doctor, right? Because if you have the order there, it's okay because it's just seeing whether you're matching the two together. You shouldn't have a history of bacterial febrile, right? Because if a patient has it, there's a complication with the procedure of the medication, of the administration, okay? That's a nursing problem or blood tubing problem, right? So that's a procedural thing, right? So we always medicate bacterial febrile with Tylenol after we take down the medication, the blood. All right, so stop transfusion, so on and so forth, and we're not going to go through that again. All right, let's move on. Okay. All right. All right, so let's talk about shock. All right, so we talked about not needing to know this. This we kind of know. We've talked about cardiogenic shock and hypovolemic and also septicemia. Neuroshock we're not going to test on in this content because neuroshock was covered in a neuro test, right? So you don't need to restudy that stuff. So that objective was already met in that one. All right, so we're going to get right into septicemia because septic shock is the priority. All right, so it all starts with the patient. No, just kidding. And we'll move into it. So yesterday we talked about that chaos, right? So, I mean, it's just a principle of introducing the content and then moving on, right? And also the clotting cascade. We talked a lot about the clotting cascade yesterday, but that's, you know, that's nuts to know, right? So, I mean, the concept is the risk is bleeding. That's all you need to know, right? So bleeding is the issue. And if you see bleeding with a septic patient, that's acute, right? So they progress to the stage of no return at that time. You're going to call the family, you know, this patient is going to die. And that's what that means. So think of DIC and those type of things. So that's the big issue with this. So if you see bleeding, that's acute. But we talked a little bit about why that was, and that was a clotting cascade, and that's what that was all about. But you don't need to know all that data, okay? Why do I talk about it? Because you have to understand why we're doing what we're doing, right? And why a patient would bleed. Because you're like, okay, they're septic. Why are they bleeding? That doesn't make any sense. Well, the clotting cascade, that's why. Right? But we've talked about the clotting cascade before with Coumadin and heparin. We added on some things with hemophilia yesterday, and we talked about that would be which factor? Does anybody remember for hemophilia? For von Willebrand's? Yeah. Right. See, nurses, I mean, it's what it is, right? I mean, when you think about it, right, it's crazy, right? So, you know, it's just one little, that's the important thing about lecture. It's just that, you know, I mean, we talk about it, I mean, and then just, you know it, right? So it's pretty cool, you know. So factor VIII deficiencies, right, is von Willebrand's, right? And that's acute. And that's why the patient bleeds. And that makes sense why a patient is a hemophiliac. They can't clot. So they're always having these risks of bleeding and stuff like that. So that's an important piece. Okay. So we get out of that. So let's talk about sepsis. We're going to start to break it down now, okay? Not the way we broke it down yesterday, but more in the sense of what do we need to know? How do we need to know about this, right? So, so let's start with that, and let's get into it. All right, so sepsis. All right, so sepsis is basically like this. When we're talking about shock, you know, this is the model that we look at. This is my model, this is somebody else's model. And up here, you know, is the brain, and down there is the feet. Okay, so essential, right, and non-essential. Okay. So the priority action is this is priority, right? Brain's priority, right? Because we think about mean arterial pressure. Okay, so brain requires 70 to 75 of mean arterial pressure. Right? Where the skin and such like that is not priority action, right? It's secondary, you know, where, you know, more important is that we perfuse the brain. Okay, so we have three different areas here. We get the vessels, we get the pump, and then we have this, see this, VSVR, systemic vascular resistance. Okay, so the vessels and their ability to squeeze, all right? All right, so let's talk about one at a time. So we're going to talk about shock, and we're going to start to lay it down. And what we're going to do is we're going to go back to this sheet over here. Come on. And we're looking at this piece right here. Okay, and that's kind of what we're going to do. We're going to walk through these three things as we look at this model. All right, so so we start, right? So we have BP. Right, we have heart rate. We have mean arterial pressure. We have cardiac output. We have heart rate. We have SVR. We have CVP. We have JVD. We have PAWP. We have stroke volume in there, and then we have pulse pressure. That's not most likely to be tested on, okay? Because pulse pressure we talked about with widened pulse pressure with neuro patients, and that's where that is tested. So more important is that you know this stuff. That's most important. I mean, this is all nuts to know. Okay. All right, so let's talk about one at a time, and this is the best way to do this. So I always think of this as being the volume here. Okay, so a patient, let's take hypovolemia first. So we have hypovolemia, we're talking about hypovolemia shock. So a shock patient who is hypovolemic, hypovolemia, right? So no fluid. So you think of it that way, right? So this pump is not filled, right? So the vessels out here are all, there's not enough there. So if this is going on and this person is laying down and they sit up, this is going to swish, right? And they're going to get dizzy. So that's orthostatic. And that's why. So orthostatic patients are very hypovolemic, right? So that's an important concept. So what's the rule? right? You fill the pump, right? So if the patient is hypovolemic, dehydrated, mentation, restlessness, all those things become problematic. So therefore, what happens to the heart, right? So the heart rate will go up. So heart rate goes up. So how I want you to set this up is, sorry, I'm working differently how I normally work, so just bear with me. So I'm going to go back to this just to kind of show you what I'm talking about, how to set this thing up. All right, so what you want to do is do this. And you want to say this is heart, right? No, this is hypovolemic first. This is heart, and then this is septic, okay? And then you're going to go blood pressure, heart rate, and so on. All right, so that's how you'd set it up to look at. All right, so let's kind of walk through it. So the blood pressure, would it be high or low? Well, I mean, there's no volume here, right? So the blood pressure will be low. Heart rate will be up, which makes sense. So the mean arterial pressure, well, there's not enough blood and there's not enough volume, so mean arterial pressure will be low. All right, so what about cardiac output? Well, that's a little bit strange because, well, the heart is going to be pumping, right, to meet the demands of the brain. So that's going to be kind of a little bit variable, right? On the long term, I mean, there's not enough volume, depending on what it is, but it's going to start to increase the cardiac output, right? And that would make sense because it's trying to meet the demand. The brain's saying, hey, I can't take this. There's not enough volume here. Pump up, pump up, pump up. So catecholamines, everything like that, are going to pump and keep the cardiac output, which means that the ejection fraction, right? So that ejection fraction will also be very variable, right? Because how much is the volume? How much is it not, right? So how much percentage of blood is coming out? Well, if we don't have enough volume, because hypovolemia can not only be fluid, it could be hypovolemic shock, like hemorrhage shock. Hemorrhage is basically hypovolemic. So if you don't have enough volume, so the ejection fraction will be less, right? Because there's not enough volume to pump out. But that will be variable as well because it relates to the cardiac output. So the next thing is SVR. Well, we said SVR is over here. Okay, this is alpha. Alpha. And what this means is, so think of all these vessels out here, all your alpha out here. Okay, so out here, so think about this, is that what is it going to do? Is it going to open up and vasodilate, or would it constrict, right? Well, natural mechanism is, well, holy crap, there's not enough volume. So let's vasoconstrict. So SVR, systemic vascular resistance, will start to squeeze. So SVR will start to go up because there's nothing wrong out here. This is a normal mechanism out here to maintain what's going on with this body over here. All right, so CVP. Okay, well, central venous pressure. All right, so we're looking at the person, and we're looking at this person. We see the volume peripherally, outside. So when we say that we think about CVP, we think about edema, right? So a person with edema of +4 has a high CVP, right? A person with a 0, right, or has a lower CVP, right, on edema. So see the volume peripherally. Well, if they're hypovolemic, they're going to have a low CVP because it's about fluid volume. So low CVP. JVD is the same thing. That's Arkansas, right? So, like I said, Aunt Josephine, Uncle Joe, they're taking the same exact test, but they don't have those fancy swans and putting in all this stuff. So they look at the person. Do they have JVD or not? Well, if they're hypovolemic, they won't. So that would be less than 4, right? Or less than 5. It's a little bit different as far as how we assess JVD. We talked about it in the cardiac, and so you look at that lecture. All right. Then PAWP, pulmonary artery wedge pressure, left atrial pressures. So lungs, right? It's that side. Well, it's all about volume, so it's going to be low. So this patient will be low wedge pressure. And then we said that those numbers are, we said cardiac output is, 4 to 8, right? And then we said CVP, 4 to 8 we want, wedge pressure, 8 to 12, and this is all stuff that we already know, right? So now SVR is new, and so SVR is generally I've seen 6 to 12. I've also seen 7 to 12. Okay, so kind of all over the place, which means that SVR will be just talked about as far as SVR is concerned, not having actual measurements. All right. So does that make sense as far as how we look at this piece here and how it maintains, hemodynamics? Okay, so that's a normal person. Everything's working here. So that's what's going on. So just stay with that. So if you draw this person out and then you kind of look at it, it just makes sense. You have your volume over here, the vessels, you have your heart pumping, which it should be, and then you have your vasculature that which should be working. There's nothing affecting any of this stuff. So except for this low volume in the pump. All right, so let's go to the next one, which would be cardiac. All right, so heart problem. Well, here's the issue. This heart not pumping, right? Okay. Well, if it's not pumping, is the blood pressure going to be high or low? Well, it's going to be low, right? Well, if the brain isn't being perfused, right, is the mean arterial pressure going to be high or low? It's also going to be low because blood pressure is low, which means that this mean arterial pressure is also going to be low. So that's a problem, because when you're looking at, stroke volume low, yes, because stroke volume will decrease when a person is hypovolemic, right? So, all right, so what else is it? I forgot. All right, so heart rate, mean arterial pressure. So the heart rate will start to go up, right? Because the brain's not being perfused. So the heart rate is assessed from the SA node, right, which comes from the brain, and it's going to say pump, 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 pump. But the heart's broken. You're in cardiogenic shock. So what we need to do is that it's going to keep on pumping. And, that's just a mechanism of trying to treat it, but then it's going to cause further problems. So the patient's going to get ST depressions and ST elevations. And we talked about this in cardiac. All right, so what about the fluid over here? CVP. Is it going to be high or is it going to be low? Well, think of CHF, congestive heart failure. Heart is failing, so therefore the volume will start to fill up. So CVPs will be high, wedges will be high. But what about this section over here, SVR? Well, that's also going to be high, right? Because there's nothing wrong out here in the vasculature. All it recognizes is that, hey, wait a second, I'm not getting perfused here. So that body is going to say, holy crap, no blood pressure, no mean arterial pressure, squeeze. What happens with that? All the blood squeezes and goes back to this heart, right? So this heart gets fluid overload because of the squeeze. So think about that. So if this is vasoconstricting back here, we don't want that to happen because the heart's broken. If we know that person's in cardiogenic shock, we don't want vasoconstriction out in the SVR. So what we're going to do is we'll put them on nitroprusside, where we're going to vasodilate them, open them up, because we know, wait a second here, this person's heart's not working. Don't be vasoconstricting. Nitrates, those type of thing. Nitroprusside. So we're going to open them up and let them become relaxed. Okay. So what do we do for this patient? Well, we give them nipride, we give them nitroprusside, we treat this over here. We might give them some dobutamine to pump that heart, or dopamine to pump that heart. We'll talk about that as we move into sepsis. So those are your two shocks, you know, blood pressure, heart rate, cardiac output, SVR, CVP, wedge pressures, and stuff like that. It makes sense because, decreasing the demand on the heart, right? Because you're basically going to give dobutamine to pump this heart for it, right? So we're just going to pump it because right now we already know it's broken. It can't pump on its own because of whatever reason, myocardial infarction, myocarditis, so on and so forth. So what we need to do is put some medications in there that it's going to pump. And that's like dobutamine, dopamine, okay? We're not going to hang up vasopressors. No kidding, right? Because vasopressors, V, A, alpha, why would you want to squeeze this patient? So don't give them Neo. Don't give them Levofed, things that are going to squeeze them. Because the problem isn't out there. Well, that's making the problem worse. We want to vasodilate them. So then we make them a little, and then we treat the underlying cause. So we're going to try to pump that heart, and then we might give them like Lasix or something like that to gently diurese, deal with this fluid problem, to let go of that fluid. All right, so with that said, we're going to move right into sepsis. All right, so that's the concept. All right, so this is the process. This is what we're looking at. So let's go right to sepsis, and we'll take it from there. All right, so we still have the same things. So we have heart rate. We have cardiac output. We have BP. We have EF. We have mean arterial pressure. We have, I forgot skin. That's another one. Skin. We have CVP, JVD, PAWP, wedge pressures. And then we have stroke volume. We have SVR. Put that in there. And then, did I forget anything? All right. So let's talk about sepsis. All right. So once we understand this model, then we can go to sepsis. And this is how we'll start to do it. So we're going to look at sepsis, and then we're going to go through those sheets because then it becomes easier to see those sheets and what we're talking about. All right. So yesterday we talked about sepsis, and we said that there has to be a mode of entry, right? There has to be an infection of some sort that causes the migration of bugs to go in. Well, these cells are all aerobic. They require oxygen. And we said that, you know, and then the further on down, they still require oxygen all the way down here. Well, if a person has infection, you have inflammation. And when you have inflammation, what happens is these red blood cells and everything like that have more difficulty passing oxygen in this area. Okay? So what we have is that they're trying to give out oxygen, right? Because they're carrying oxygen. And then, but they can't get to these cells that are way down here. Okay? So now they're in oxygen deprivation. But the cells, they don't die. They go into anaerobic. And so what happens is that they're no longer aerobic. And aerobic is fine. I mean, it's what we are, you know, aerobic exercise, all those type of things. But when you have cells that are starved, they start to spit out lactic acid, right? That's the product of cells are being starved. So now all of a sudden, this lactic acid goes out into the bloodstream, right? So we draw a lactic acid on this patient. So if a patient looks like they're septic, right? You have a high temperature, they're warm, right? And they have a high heart rate. They draw lactic acid, looks like sepsis. And that lactic acid is positive. Well, the risk is they were euvolemic before. And then what happens is they vasodilate. And that fluid is not enough for that patient. Okay? So they are now in a hypo, if you just think of it that way, a hypovolemic state, because of this vasodilation. So what's the problem there? Well, the issue is this vasculature over here. What are we talking about here? This area, okay? This SVR, it's all in this area. That's the problem. So they have mass vasodilation and in the presence of lactic acid. And so what happens is that blood pressure plummets, right? So we're like, holy crap, the patient's very hypotensive. And then hence what we talked about yesterday, we start to go boom, 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 we start to do all these things. So let's take it one step at a time. We draw lactic acid, and then based on that lactic acid, we're going to fill the pump. So that's the next thing. So then we're going to give a normal saline, 4 to 6 liters. That's a lot of fluid, okay? And because they are no longer SVR over here is going to be low. It's no longer going to be squeezing, right? Which is SVR. B is alpha, is not squeezing. So what's going to happen over here? Well, heart rate will definitely go up. Think of fever, right? Cardiac output will start to increase. Blood pressure will be down. Ejection fraction volume depends on the stage. Is there volume on board? Is there not volume on board? So this is going to be variable. Mean arterial pressure will be down. The skin will be hot. CVP, depending on the stage of sepsis. If they first come in, they're going to be low. Once we fluid resuscitate them, their CVP will be where it's supposed to be, and it's supposed to be 4 to 8. Then JVD, same thing, and then wedge pressure, same thing, 8 to 12. So here we are, we're managing all these types of things, so we're going to give them fluids, then we're going to start to put up antibiotics to treat the infection, okay? We try to oxygenate them, right, and hyperoxygenate, all those type of things. So this patient might need 100% right away, then go down to 90, then titrate that oxygen down. Okay, nothing is wrong with the heart. It's still pumping. However, this heart is now pumping 4 to 6 liters of fluid. So that's a big issue. So now we start to talk about medications. So this is where sepsis comes in, and it gets very complicated about how we manage it because we have to look at medications. So the first thing is medication of choice is norepinephrine, which is level fed, right? So level fed, leave them dead, we used to call it, right? Because it was last ditch efforts. The last thing in the box that you could throw at a patient that's going to help them survive. And what is it? Well, level fed is beta and alpha. So think about this. The patient has high volumes and they have no squeeze. So level fed is a perfect medication for that. So level fed you put up and it's going to pump that volume that it has and it's going to slowly start to squeeze the SVR. Okay, that's an important concept because now we're squeezing that patient and we're pumping that patient. All right, and that's why it works, is because it does both of them, all right, at the same time. Okay, so out of the gate, it's going to give you some beta and some alpha. All right, so that's one medication. But what if we like, okay, well, they can handle the fluids, but we just need to deal with the SVR. Okay, we just need an alpha medication, and that would be Neo. And Neo is just going to deal with this SVR. It's just going to squeeze. All right? Why do we pick one over the other? Depends on the patient. Doesn't really matter. Okay? It's just being familiar with the different medications. Okay? All right, so let's talk about the next medication, dopamine. Right? So dopamine is, we talked about this in cardiac, where we said dopamine is 3 meds in one. It's a great septic med because dopamine on 0 to 5 is generally beta. Okay, 6 to 10, it's beta, and alpha. And greater than 10 is only alpha. What I'm talking about here, this is micrograms per kilogram per minute. All right, all these things are micrograms per kilogram. You're very titrating the medication based on the micrograms. All right. So why is dopamine a perfect medication, right, for this? Well, you can do what Neo does, Levofed does. You can give it some beta and alpha, and you can titrate it. You can titrate it up and titrate it down. If you just need alpha, you can move it. So that's how it works, you know. So it basically can move with the patient if you're dealing with this problem or you're dealing with this problem. And that's what you're trying to look at. You're looking at these type of things and stuff like that. So that's dopamine. You know, Lasix makes sense because you're giving so much fluid. We're always trying to prevent pre-renal failure with this type of patient. All right, so let's talk about the issues with this, right? Well, I mean, it's critical in the sense that what we're looking at here, but the big problem would be that the patient is goes from hot to cold. That's always a problem, okay, with a septic patient, all right? Or the patient starts to bleed. Right? We talked about that earlier. They've used up all the clotting factors, now they're bleeding. Losing from the sites, call the doctor, that's a problem. Patient goes from hot to cold. Okay, what's the issue there? All right, well, it goes back to this over here, this SVR. And this is called shunting, right? So usually we're hemodynamically, we're kind of treating the brain, treating the body, and that's kind of what's going on, right? So the brain's getting perfused, body, blood's getting, oxygen's getting everywhere. All right. In a septic patient, once they are no longer hemodynamically stable, for example, the rest in the digest, the gut, the skin shuts down, it's shunted right to the brain. So it's saying basically, screw you, skin, I'm getting perfused. And so you have that shift of the patient, and they're going to die. So now you're going to start to see, you know, liver enzymes, multi-organ failure, BUN creatinine, everything start to break down, and all these types of things, because the patient is finally shunted away to the point that it's in survival mode. It's just trying to perfuse the brain and what's going on, and the boat has gone, and the patient is now shifted. And that's a big issue because, you know, I mean, if that happens, call the doctor. That's acute problems. So what do we do for the patient that doesn't shunt? Well, shunting is a problem. Hot to cold, always a problem. Doesn't mean that fever broke. It's sepsis, right? So it doesn't work that way. So what you're having is, holy crap, the rest and digest is no longer being perfused. The brain is in survival mode at this point, and that's acute. All right, so what do? So we give normal saline, we give vasopressors, we give dopamine, Levofed, Neo, we feed the patient, we put an NG tube, we put them on a vent, and all that, so the skin feels cold, and everything goes cold. So which means that the brain is only in survival mode, doesn't care about the skin, and that's it. That's a big issue. Which is the opposite for hypovolemic and cardiogenic, right? Because the skin is cold with those patients, right? Diaphoretic, all those type of things. All right, so what happens? So what's some things that we can do for this patient? How do we know the cells over here are being oxygenated? Okay, so that goes back to labs. Okay, so there's a thing called the SVO2, right? Venous oxygen concentration. All right. So now we know that a PaO2 is 80 to 100, and we saw in neuro, we saw 60 to 80. You know, and it's based on oxygenation, but we're not going to go there right now. But what's the SVO2? Well, this is pulmonary artery oxygen, right? So that's how the red blood cells have oxygen on them, okay? Well, once they go down to the fingers and toes, they come back as SVO2. And they go back to the heart. So that's SVO2. So what I should have is this heme group is 4 hemes, right? So it has CO2 on it, CO2, has O2, it maybe has some hemoglobin. We talked about that before, hemoglobin A1C. But O2 in an acute situation. All right, well, if this SVO2, what should that be? That should be 60 to 80%. So once it's gone to the fingers and toes, it's lost some oxygen, and it's coming back at a percentage of oxygen, venous, not arterial, venous, of 60 to 80%, okay? Well, I want this V to 70%, okay? I want the SVO2 above 70. Think about it. If the patient is being oxygenated, I can base how well those cells are being oxygenated based on how much SVO2 is coming back. So if I had an SVO2 of 50, holy crap, there's a lot of loss of oxygen. So I'm going to increase the FiO2 on a ventilator, right? So if I was doing a normal concentration of 50%, I'm going to raise it up 65%, 70%, MD my decision, right? But it's based on that SVO2. So we use the SVO2 to monitor the patient's oxygenation of their cells in their body. The lower the number, the worse they are, okay? In a normal patient, you or I sitting here, our SVO2 should be 60 to 80%. So that's why people can generally become hypoxic and you don't have cellular death until 3 to 5 minutes because you still have circulatory oxygen in the body. That's why we start to do CPR right away and start to get things going. Okay, what's some adjunctive treatments for this patient? Well, I mean, if I need and I can't get this up and they're bleeding, I might give them blood. Right? That makes sense, right? To increase the bioavailability of hemoglobin to carry oxygen. Right? That would make sense. What else could I do? I'm going to feed them to repair the cells. I'm going to TPN. I'm going to do lipids, fats. I'm going to put them in H2 blockers. And then we go from there. All right, so that's sepsis, and that's how it kind of gets all pulled together. So let's look at the sheets now, and then kind of look at what we've been talking about. All right, so this sepsis bundle is kind of what we do in sepsis, right? So this is really kind of cool because of a lot of times these sepsis changes and they try to work on different ways of treating it, and there's a lot of issues with it, and when they work on the content, there's a lot of research on it. So it's good, you know, so we're always doing things to, you know, sepsis kills, right? So, I mean, it's a #1 killer. So we want to really make sure this patient's treated effectively. And also education is very important about it, you know, and also to be that nurse to talk about these things and say, why aren't we doing this? Or what about this? And those type of things. All right, so let's talk about it. We're going to run right through it. All right, so sepsis bundle for suspected sepsis. In the first 3 hours. Now, are you responsible to know the rules? No, you're not. You're just supposed to know what sepsis is, lactic acid, what vasopressors are, those type of things, but not this rules and all that stuff. This is all current practice. All right, so but just stay with me. So measure lactic acid level. We know that, right, because of lactic acid is the presence of starved, oxygen-starved cells. Obtain blood cultures prior to administration of antibiotics. No kidding, right? I mean, do 2 sets, separate sides. So if I think it's sepsis, I'm going to do a lactic acid. I'm going to do antibiotics, and then I'm going to start to give you broad spectrum antibiotics right away. You know, later on, I might switch it, right? Now that's when infectious disease comes into play, and then they start to switch it, right? Because they're like, okay, well, this is the bug, it's susceptible to this, let's give them this. All right, and that's where that comes in. Then we're going to administer 30 mLs of crystalloid. Hey, crystalloid shows up again, right? So that would be a normal saline or LR, right? For hypertension or lactate greater than or equal to 4. So lactic acid, I always think acid 4, right? 4 letters, 1, 2, 3, 4. So that's 4. All right, so you just need to know lactic acid. So now 30 mLs per kilogram, okay, generally will equate to about 4 to 6 liters. So you, like I said before, you're filling this pump up, and that's what you're trying to do. So you fill the pump before you squeeze, and then you go to the next step. So this must be completed within 6 hours, right? So this might happen right in the ICU. No, not the ICU, in the ER. This protocol starts right in the ER, right? Get things going. Right? So put the fluids up. As soon as you know sepsis, you start to do this treatment right away. On the floors, we'll start to do draw lactic acid, then holy crap, we need to do blood cultures. Then we'll see what it is. Then orders will start to come in, fluids, all that stuff. Okay. Once they go to the ICU, vasopressors, right? Usually level fed first because it's the ideal one for it. Right? So norepinephrine over here. And then, because they're saying if it doesn't respond to fluids, because remember, we just filled the pump up. So hypothetically, you had the heart, you filled the pump over here, that was vasodilated, and you're hoping that they're euvovolemic, but they're still hypotensive. So arterial pressure is still in the crapper, blood pressure is low. So you filled the pump, then you squeeze, right? So that's the rule. Fill the pump, then you squeeze, right? Because otherwise, if they were not filled and you squeeze this, you're not squeezing anything. There's no blood pressure. You're not going to have an increase. It's not going to do anything for this blood pressure. So it's just going to, so that's why you want to fill it. So that when you fill it, then you squeeze it, then blood pressure will go up. That makes sense. All right, so if persistent hypertension, right, and is lactate, reassess volume status, perfusion. What do I mean by that? Well, I'm looking at CVPs, right? So CVPs, wedge pressures, cardiac output, talking swans, Viglios, different things like that. All right, so we said cardiac output, right? CO becomes, put an O over that, that becomes half of that. It's 4 to 8. Once we have that, we have CVPs, that's 4 to 8. Okay, so see the volume peripherally, right? So CVP is out here, so think edema. Then you have wedge pressure, PAWP. That is, add these two together. You have 12, and then you bring this over there, you have 8 to 12. All right. So then you also have SVR, which you'll be monitoring because that's the systemic vascular resistance. All right, so what else we have? We assess volume status, we measure lactic acid. Okay, and so based on this lactic acid, then you continue with it. And then that's what we do. So the Merrick protocol, this is sort of new science, and this is really kind of cool, is that, they found out that vitamin C at high doses will cause that patient to recover faster, which is really fascinating. I went to this conference, and it was, they were going to talk about sepsis and all these type of things. And I wanted to hear about this protocol and all this stuff. They didn't even talk about it. I was so pissed. I'm like, why the hell would I pay for this? It's some BS, same old stuff. So Merrick protocol is very cutting edge and very effective of treatment of sepsis. However, vitamin C, $2,000, a shot of this vitamin C. So it's very, very expensive. They find that high doses of vitamin C, we're not talking popping pills, we're talking IV vitamin C, very, very expensive. They're used a lot of times, different alternative doctors use this for cancer patients, and they find high doses of vitamin C. It's very effective for cancer patients to get their tumor markers down and different things like that. We know vitamin C is very important and stuff, but IV vitamin C, good luck with it. It's very expensive to get. You can't get approval for it because they call it not necessary needed medicine. obviously. So hydrocortisone makes sense. High dose steroids. Assess and add vasopressors as needed. Thiamine, which is interesting too, right? So now we have support of thiamine, and it's something with the liver and the liver's processing of the vitamin C and the metabolism of it, how it effectively deals with the infection. So pretty fascinating. However, you don't see it much. A lot of times they don't do it. So, I mean, it's always good to kind of talk about it. Like a lot of times I'll talk to doctors and different things, and I'll say, oh, you know, why don't we ever do like the merit protocol and different things? Just feeling them out, seeing what's going on and stuff like that. But you don't see it. So, I mean, it's kind of one of those things that hopefully, you know, maybe sometime we'll see it. But, I mean, there's more medications. You know, I mean, it's a good study to see. All right, so anyways, BP we know, okay, cardiac output we talked about, heart rate we talked about, SV, stroke volume, SVR we said low, ejection fraction, skin hot and cold, JVD, CVP, wedge pressure we talked about. And gaps will tend to just basically, that's based for fluid, bilirubin, that comes from here. Why is bilirubin most important? Because of multi-organ failure, right? So once the liver starts to get affected, that becomes a problem. So we're always monitoring all the organs, BUN, creatinine, nocidin, pH, PCO2, bicarb, nocidin, D-dimers, platelets, right? Platelets because of, what the hell am I drawing there? Platelets because of DIC, because of mass bleeding and with septic patients. Osmolarities because of fluid. Urine osmolarity, urine sodiums because of pre-post renal. Fibrinogen, right, goes back to the clotting cascade. Is it extrinsic or intrinsic? Extrinsic, right, because fibrinogen, genus starts, is extrinsic factors. Plasminogen goes with fibrinogen. SVO2, which we just talked about, PaO2, we talked about in specific gravity, all about fluid. Over here you have phenylephrine alpha. This tells you that it affects only the systemic vascular resistance. Then you have vasopressin. That's not used as frequently. Levofed, epinephrine, not most frequently. Isopropanol, natracor, not most common. Most common is dobutamine and dopamine, and then millerone. All right, so alpha agonists, fat beta, that's just explaining what these are. So that's a sepsis protocol. That's how it works. We'll move to the next thing, which is a SOFA score. And this is another score that we kind of predict the outcome of the mortality of the patient. Nuts to know, don't need to know, okay? Because a lot of times it's very difficult to get. It's like a RAS score. Like we'll talk about that with trauma. You know, GCS is most likely, not a RAS score, which is the Richmond agitation sedation scale. All right, so for sedation. So a SOFA score, what is it and why is it here? It's just to kind of get an idea of what we're talking about here. So, you know, we've talked about PaO2 and FaO2 ratios. So that's why it's so important, right? And that's what I was talking about. Like the PaO2 is important, but how much oxygen are they on too, right? So are they getting ventilated with an FaO2 of 60% or not, right? Then you have a Glasgow Coma Scale. That makes sense. Liver involvement. Is the liver now involved? Because if the liver's involved, you lose the liver, patient starts to die. Okay, so that's once that organ goes, all the other organs will follow. Platelets, that means that the patient is bleeding now, so that also makes sense about mortality. Once you start to lose clotting factors, you start to bleed, you have a higher risk of mortality. Then we get into mean arterial pressures, right? So you get points for all this stuff. If they're on dopamine, because they're not compensating for themselves, and then you see all these, you know, level fit and so on. Then you have your kidney score. So how well is the kidney? Are they in pre-renal, right, or intrarenal at this stage? And then they give you a maximum SOFA score. You're not tested on this. It's kind of cool to see because, I mean, it's all stuff that we've kind of talked about. And when you see everything that you talked about and you pull it all together here, it's pretty fascinating when you start to see that, you know, there's actual, how much you actually do retain of the content. What else we got? So that's a surface goal, not tested on, just kind of nuts to know and not need to know. SVO and decrease in lactate indicates patients increase in SV2. Yes. So increase of SVO2 and a decrease in lactic acid means that's good, right? And hemodynamics, blood pressure goes up, mean arterial pressure goes up. You remember? So, and then we follow like acute renal failure, right? So if they're renal failure, we're looking for a diuresis stage and so on. All right, so let's talk about albumin. And so when they're in the diuresis stage, right? So now all of a sudden they're starting to urinate, right? So they are third spacing, right? So they're like this filled up person, right? And they're weeping, edema, so they're +4s and different things like that, right? So a lot of times what we'll do is that we're going to give them albumin. And what that albumin will do is it's going to pull all this +4 into here, okay? And then it's going to, so coupled with that, so all this extracellular fluid is going to get into the vasculature. But you want to support that going out because it needs to go out through the kidneys, right? So you want to make sure that the creatinine and their BUN and their GFR is all A-OK before you start to do that. Make sure that they're urinating because if you're pulling all that fluid, the albumin, and it pulls it in, remember it's like a sponge. So if we spill water on a table and we put a sponge down in the middle, it will slowly pull all that fluid in. So that's kind of what happens in the blood. Well, if they're not urinating, why the hell are you going to do that? It's going to pull all the fluid into this vascular space. There's no place to go. So that would cause a problem for the patient. All right, so let's look at some orders really quick before we wrap it all up. So this is a sepsis orders. Obviously notify doctors, we know that. We'd want to know that, especially allergics to like penicillins and cephalosporins and different things like that, because of antibiotics is priority for this patient. We want to know code status, of course, vital signs Q1 hour. So that's pretty specific, right? So that's pretty acute. And then hemodynamic measurements here. So we said systolic less than 90. That's kind of what I talked about before. But NCLEX will test you on 100, all right? But generally in acute care, we really worry about less than 90. I think we had a question on that with like a Docinapro or something like that. It was like 96. I mean, we don't care about that. It's not a big deal. However, NCLEX says 100 is a big deal. Heart rate, even less than 50, that tends to be an issue. Call a doctor. Because it shouldn't be happening, right? They shouldn't be becoming bradycardic. They should always be becoming tachycardic. Because bradycardia, the body doesn't want to go down, slow it down. Respiratory rates will be vented most likely. SATs, okay. Urine output, we'd want to be making sure that that's okay. We'll do vascular checks. So this patient, checking pulses, this is where your cap refill comes in, all that stuff. We would mark their pulses because they're going to have so much edema, +4 and different things. We might do neuro checks because remember, they might be on a BIS monitor or something like that. We'll be monitoring sedation because they'll be on propofol or heavy sedation. Delirium assessment because of ICU toxicity or ICU delirium, being on all these sedative medications. A lot of times you want to make sure, so you'll do what's called a sedation vacation. So you'll wake the patient up, put them back down, wake them up, put them back down. But you'll do this once a shift. That's what this is. Q shift. Activity, had a bed greater than 30 cc's. I mean, think about that. They have all this fluid on board, I mean, you don't want it to be, coming down here and then popping into their brain. Also, way up here, I mean, even semi-followers and high followers, we're way past this stage. We have a stable patient, or a critical patient that we're trying to keep at this level. What else do we have? We have strict diet, no kidding, right? All care. So this all care is done because of ventilated acquired pneumonia. That's where we have the VAP tube we talked about before, because we don't want the mouth is very dirty, so we want to keep the mouth care going to decrease the amount of bacteria in the mouth. So it doesn't go down to that ET tube and potentially cause, now you have a pneumonia on top of the sepsis. So strict no oral care or lack of fluid to both eyes, that's more because of if the patient was sedated or paralyzed. And we talked about that with paralyzation in their eyes. You know, they're not blinking, right? So the eyes are somewhat open, so they dry out. So you have to kind of open them up. Anticholinergic, cholinergics, dietitian for the TPN. Moving on through ICU, blood glucose treatment protocol. Because remember, they're going to be on high dose steroids, so you're going to be monitoring that glucose, you know, for that patient, and you'll do regular finger sticks around the clock, and you'll expect it. Remember, they're getting TPN on top of it. They're also getting high dose steroids, so everything is really, really, really acute. So it's going to affect their blood. So sometimes these patients get insulin, you know, and that's not uncommon for a patient. All right, so hypoglycemic protocol, because if they're getting insulin and they normally don't get insulin, they're producing insulin. They're not a type 1 diabetic, they're not a type 2 diabetic, but they're getting all these steroids and all these types of things. And so what you start to have is that the patient is at risk for, you know, hypoglycemia, because now you're giving somebody insulin who's producing insulin. So things are starting to, they could bottom out for you, and that's important. Nasal cannula, if you'd be lucky if they're at that stage. Wean SpO2 greater than 92. Bronchodilator protocol, which means that they're going to get dual nabs, ipratropium, albuterol inhalers, and Ventolin. So moving on down, we talked about the road rates yesterday. Generally, they'll be on AC mode. They're going to have a rate of anywhere from 12 to 18, depending on the PaO2. Tidal volume, depending on the patient's size. They'll all be on PEEP, okay, 5 generally, and FiO2, depending on the PaO2 and the SvO2. All right, ABG 13, this is normal stuff, and then we'll move to the next one. All right, so the next thing is sedation for mechanical medication. You either have propofol, so if they're on propofol, they're also going to be on, that's lipids, right? So you're going to monitor. Jessica thinks something's very funny. She's tuned out. And then we have, she's like, I've seen this all yesterday. I'm no longer listening anymore. All right. This is why we're videotaping it, right? So lipids, right? Lipids are important, right? Because if they're on TPM, you don't give them, and propofol, you don't give them lipids, right? So monitor triglycerides because of risk for myocardial infarctions. Lorazepam, okay, in case the sedation is not totally working. Morphine, just for comfort. Fentanyl, not most likely. We might hold this enoxaparin, depending on the patient, because of risk for bleeding. Pepsid, that makes sense, right? H2 blockers. Hypotonics, life-saving. Pepsid, same things, depending on what's going on. All right, adrenal insufficiency for critical illness. This is think of Addison's crisis. Okay, you're giving all these steroids, corticosteroids, all these things. So the patient's at risk for this kind of adrenal insufficiency. Because the adrenal glands are going to shut down because you're giving them all. And we talked about that in class. Remember, we said you wake up the adrenal glands. That's why you taper. You say, hey, wake up, because you don't want them coming out and going into adrenal crisis. And that's kind of why. All right, so we move over to this. Blood cultures, no kidding. CBC, no kidding. Differential Y for shifts to the left, no kidding. PT for bleeding. Type and cross just in case. We said that if the SvO2 is not there and they're not managing, we need to make sure that we have potential for giving blood. Thyroids, because we're messing around with it. Phosphorus, no kidding. Mag, calcium, no kidding. BNP for CHF. Sputum cultures, yep, okay. Lactic acid, yep. Legionella, why not? Pneumococcal, why not? And in case they're not getting better, we're checking for these things, right? So labs, always. Fasting, lipid panels, always. Monitors, fluid resuscitation, no kidding. Hemodynamics, that makes sense. CVP, right? So CV proximal on a triple lumen, that's where you connect that. Because if a person has a triple lumen, you can put a CVP pressure reading on and check where they're at by their proximal. Sometimes they use distal. Doesn't really matter. PA catheter, that's a swan. PA pressure is SVR. That's for your SVR. Then you have your norepinephrine, you have your epinephrine, and vasopressin, not most likely. Empiric antibiotics, not important what they get. Now, it is important for you, for NCLEX, to know antibiotics, aminoglycosides. You need to know that because they're going to test cephalosporins against aminoglycosides, everything like that. You need to know which ones are liver toxic and which ones aren't. And we talked a little bit about those. We'll talk about those more towards the end. ICU sepsis, and then this basic protocol. All right, so sepsis, I don't think I need to go through this because we kind of visually talked about it and we covered everything over there. So that's sepsis, that's the sepsis lecture, and that's the main content that you need to know. I mean, the big key is that sepsis is an acute situation. You know, what do you need to know about it? You know, the basic stuff. You don't need to go into managing a septic patient or drawing a sepsis man. You know, that's not priority for you. Most important is what's the complications of this patient, you know, and how do you prevent okay, I'll do the sheet. Yeah, so how do you prevent the problems from happening? All right, so let's go through the sheet. I think it might help. All right, so all right, let's do it. So a patient who's septic, right? So a patient presentation is they can be URI. URI could get septic because you need a portal of entry. So you need that portal of entry so anybody can have it. Patient could go to and be septic over at the doctor's office, right? They could show up, they have a fever, anything like that. You know, they have a comorbidities, they're diabetic, you know, and they're not sure what's going on. They're sick, right? So a patient with a history of pneumonia can go into sepsis, right? I mean, anything, an abscess can go into sepsis. All these factors can become sepsis. And if it becomes acute, they end up coming by ambulance, right? So they present in the emergency room. They can also be on the floor. Doesn't, you know, choose your parents wise, it doesn't really make a difference. And age, more comorbidities tends to be the issues. What's the main symptom? Is hypotension, right? Low blood pressure, right? That's the main symptom. Fever, right? That's another symptom. Everybody knows that. And then the third symptom is low blood hypotension, fever, and lactic acid. Oh, that's not a symptom. Hypertension, fever. Anybody have any brain farting? All right, I'll go back to it. All right, so precipitating, right? So precipitating, what's the precipitating factor? Is injury. There's some sort of infection or something like that, some sort of mechanism of entry of this infection. All right. So what's the main complication? Is multi-organ failure, MODS, right? Where they actually start to you lose their liver, you lose their organs. One goes at a time, right? The last ditch effort is you see the brain going. So it says stop the skin, and then next comes the organs. So we're always monitoring these labs and what's going on. What's the acute 3? The patient goes cold, right? They were hot, now they're cold, right? That's a problem. The patient starts to bleed. That's a problem, right? The patient has a persistent hypotension, right? That's a problem. So decreased blood pressure. All right, so on a monitor, no kidding, for ST elevations, ST depressions, blood pressure is always going to be monitored, more hemodynamics, swans, different things. Labs, more specific, lactic acid, blood cultures. Then you'll continually monitor your labs, right, because that's your hemodynamic status. Positioning, we talked about, right, so 30 degrees. You know, I'd be fine with 45 degrees, but not high foulas. Patients vented. And generally, we don't keep patients who are vented in high foulas. You'll do regular diagnostics as far as chest x-rays, looking at lungs and what's going on with the patient. IV fluids, up 4 to 6 liters right away, then antibiotics, then vasopressors, dopamine, dobutamine, neosynephrine, TPN, lipids, or propofol. So a lot of medications on board. Steroids. What else we got? We got monitoring definitely sodium, because fluid shifts are going to be all over the place. They're going to be up and they're going to be down. They're most likely going to be not so much hypernatremic. They're going to be hyponatremia, but more that you're going to have to figure out because you gave them so much fluid that you don't know which one it is. and you're trying to figure out what kind of, are they euvovolemic, are they hypovolemic, or are they hypervolemic? R&R, white blood cell count. Okay. Yeah, respiratory or high blood pressure, heart rate, tachypnic. Yeah, heart rate, tachypnic, that's a good one, yep. Yeah, I'd put that heart rate definitely high, as far as being presented in a question type of thing. They need assessment, right? It's a acute situation, but you need to have that mechanism of coming in. So potassium, definitely an issue because of diuretics. Chloride and CO2 is going to be all over the place because this patient's going to be very acidotic, alkalotic, and they're going to be going back and forth. BUN creatinine, always monitoring in GFR, because this patient is going to go from acute kidney injury to pre-renal to intrarenal, and that's what we're going to be looking for. Glucose is going to be all over the place, requiring blood sugars and requiring constant monitoring, and also might be getting insulin, so they become hypoglycemic because they're getting insulin around the clock, and also the kidney, their pancreas is still secreting insulin. So it's a very iffy situation where type 2 diabetic, you're treating with oral glycemics, right? Because you're trying to treat, say, hey, they have some insulin, let's try to make it available, right? That's totally different than this. White count would definitely be elevated, highs, 24s, 28s. You look right down to the differentials, see neutrophils, you look for shifts to the left. You won't see eosinophils, basophils, and all that stuff, unless they start to go into inflammation. Hemoglobin H and H, if they start to bleed, that becomes an issue, so we'll start to look at the H and H, and that'll be low. We'll also look at dry in the early stages, right? Because the patient is going to be dry, we're going to look to whether or not this person has a highest dry. We'll support that with blood if we need to. Platelets, we're going to look as a late sign. Calcium and mag, more on electrolytes and diuretics. Think about that. Magnesium goes out by diuresing. So if you're giving a person who has a Lasix strip, they're pouring out this magnesium. So think of an alcoholic who drinks, right? So alcoholic who drinks pees a lot, right? More than they normally would pee. So they start to lose more magnesium over time. And if they're not eating magnesium, they become hypomagnesium. So patients who are alcoholics tend to be hypomagnesium, right? Calcium, mag, phosphorus because of diet, and also liver. Liver enzymes because you're given all these antibiotics and these nephrotoxic medications that you have to be monitoring this liver. Also for shunting, that the patient is actually starting to lose their organs. Amylase, lipase, same thing. You're giving insulin, you're monitoring the organs. One organ goes, the next one goes, and so on and so forth. Remember, this patient is sedated and out cold. You're giving them high lipids, propofol, so pancreas is going to be overworked, all these types of things. Bilirubin, well, that means they're moving from conjugated to unconjugated. The liver is suddenly starting to break down. And once it starts to break down, then we start to see liver failure starting to kick in. Temperature, high, right? Then it becomes low. Pulse will always be high. This patient will be tacking out 130s, 140s. They'll be on a ventilator. Blood pressure always monitored with a BP cuff and also an arterial line. Mean arterial pressure is gold. You always monitor that mean arterial pressure to maintain perfusion of the brain and what's going on. And pulse ox, we don't care so much about the pulse ox anymore. We have an ABG. We're going to be looking at SVO2. We're beyond pulse ox at this stage. It's good to see. It's not like we're like, oh, well, it's septic. We're not going to put it on. We'll still put it on there, but we're not going to treat that specifically because they're on a ventilator. We work more on the SVO2, the FiO2 on the vent, and the ABG, PaO2. It's all about fluid. Their pulses are going to be all over the place. The ABGs are going to, oh, this is not ABGs, that triglycerides we're going to monitor because of propofol, and cardiac enzymes will always be monitoring. BNP, remember, we are pumping this heart failure. They get a lot more pressure on this heart, so they'll have elevations of BNPs. We generally don't draw them because the heart is stressed out. It's going to be elevated anyways. ABGs are gold again, because we're constantly managing this patient. Remember, we can't see this patient, so we'll have a BIS on them or something like that. Now, BISs aren't universal. You don't have them everywhere. So some places, oh, we believe in them, well, we don't believe in them, whatever. You know what I'm saying? The thing is it's a thing that you can use to monitor the sedation. Heart is always treated with either dobutamine, dopamine, and lungs are treated through the lungs. Kidney problems are always monitoring. These patients don't go to surgery, right? They're septic, right? So they stay in the ICU until they can be resolved. Can they walk out of the hospital? Yes, they can walk out of the hospital. Will they be discharged? Nope, they're going to get the ICU, CCU, and what's the main complication is that they die. They go to multi-organ failure. So the nursing 7 of it is definitely symptomology, lactic acid, hemodynamics, CVPs, wedge pressures, vasopressors, alphas, beta block, like dobutamine, dopamine, being aware of those things. And that's kind of nursing 7 as far as this sheet is concerned. So this patient is pretty sick. I mean, so it becomes pretty complicated when you talk about management of this patient. Now start to do questions. I mean, the good thing about sepsis questions is they're big. Shock questions they want to give you a lot of data, and then they want you to figure it out. Saunders is very big on sepsis questions, where NCLEX will test more on your understanding of lactic acid, blood cultures, these type of things, antibiotics and stuff like that, and hemodynamics, like knowing what a CVP is, knowing what a wedge pressure is, most likely CVP. And then going from there. All right. Is there any other questions?